begin by saying that managed care per se is a morally neutral concept. That the idea of putting the physician, the clinician, the nurse, decision-making within certain constraints is not of itself intrinsically evil. We tend to move in that direction sometime without reflecting sufficiently that, as a matter of fact, we've been doing managed care in an informal way with a different intention than managed care when we had tissue committees, when we had pharmacy and therapeutic committees, when we had formularies, when we had morbidity and mortality conferences. That was managing care with an end in view of helping the patient, increasing the quality of care. So the first point I'd like to make is that managed care per se is not intrinsically evil, that its moral status depends upon the intent, the consequences of that particular plan on the care of the patient, and the way the priorities are set and resolved when they are in conflict with each other. So it is possible to have managed care which has a Christian inspiration to it. However, the problem for this afternoon is managed care as it exists. And that's what I will address myself to, but looked at from the perspective of how does it measure up against a Christian ethic of care. One thing that wasn't said in the introduction, and I think I have to say it so to establish my credentials, I am a professor of medicine and ethics and philosophy, but I am a physician, and I do still see patients, although on a limited basis, but within a managed care setting. So I speak from a certain degree of experience in my own life. Every clinician knows that the relationship, and you've been heard about that, between a physician and a patient, or a nurse and a patient, all health professionals, is the final common pathway through which any system of health care reaches the ones it is presumed to serve. And the moral probity of any system, therefore, can be judged by the way it affects that relationship, and through that relationship, the welfare of the patient. Now today, managed care is not the only force that's altering the relationships, the healing relationship, which is the way I prefer to speak of it. We have the prodigious power of medical science, which objectifies the patient and makes the physician a technician. We have the atomization of social life, which makes the physician and the patient strangers to each other. We have the spread of litigiousness, which makes them antagonists, and the secularization of ethics, which deprives both of a stable source of moral values, and the monetarization of health care, which converts them from doctor and patient to provider and consumer. I think we have to recognize, as we look at managed care, that it is occurring within a context of other profound changes in that healing relationship, and that it's somewhat artificial to take managed care out of that context, because these forces act synergistically, and they're acting to undermine a relationship which should be a relationship of trust, of care, and of personal concern. But in many ways, managed care is paradigmatic of those other changes acting on the healing relationship. They all distort, they all substitute something other than the good of the patient as the end of medicine. It's always seemed to me curious that at this late stage in the history of medicine, we should be asking ourselves, what are the ends of medicine? What is medicine for? What are its purposes? It had always seemed to me that medicine exists because people are ill, people need help, people are vulnerable, people are anxious, and we exist because there is a universal human need which transcends all cultures, all time, all history. That view is not a popular one today. Let me look at the first aspect of managed care, saying once again that as I go through this, remember that it is a reflection of our society. The fundamental question is, what kind of a society do we want to be? And that's expressed where? It's expressed in the moment of truth, that moment of truth when we confront a patient who is ill, seeking assistance. But that moment of truth is the end point of all of the things we think about ourselves and the values we put before ourselves. And I would say today, the managed care reflects our society. Our self-centeredness, our unwillingness to sacrifice, our utilitarianism, and our adulation for the marketplace, so that we light candles to Adam Smith. Now, the marketplace has its function for many, many things, but I would submit it is not the arena for the settlement of the question of health care and how it should be distributed. Let me look first then at what I perceive to be a Christian ethic, very, very quickly, or a well-instructed, well-informed audience, but perhaps as I see it as necessary before I apply this particular perspective to some of the conflicts of obligations which I see in managed care for the healing relationship. Now, a Christian ethic would certainly begin by taking cognizance of the natural dimensions of the phenomena of the healing relationship. And those are three. First, the fact of illness, what illness does to human beings. Illness is an assault on the humanity of the person who is ill. The ill person is put into a state of anxiety, of pain, of need, of dependency. Is vulnerable because he or she must seek you and me, is dependent upon us, depending on what? On our character, has to trust us because we invite them to trust us. We imply that we will act in their interest. They understand when we offer ourselves, what can I do for you? That we are promising, A, to be competent, to have the knowledge that can help them, and B, that we will use it in their interest and not in someone else's interest. That's what you understand when you go to the physician. That's step one. In that state of vulnerability and exploitability, I might say, we offer to help. That's entering into a covenant, a sacred promise. That is our act of profession. That's what we mean by a profession, a declaration of a commitment to something other than our own self-interest. That's what distinguishes true professions, not the degrees on the wall or even the courses taken. And then finally, we expect to eventuate from that relationship, those two facts, a healing decision, one which is right technically and one which is good morally in the interests of this patient and not of society, not of the family, not of an investor at a distance, this patient presenting to us now, this human being, this wounded person confronting this wounded healer. Now, for the Christian, healing is a vocation, a calling, to which we respond as our life's work. It's also our way to salvation. It is not an occupation, a career, or an investment opportunity. We are called to nothing less than to imitation of Christus Medicus, the term that St. Augustine and St. Peter Chrysologus used for Christ. Because in his life, as you know all too well, he spent so much of his daily life healing and helping other humans. Christus medicus, Christ the physician. Now those principles and virtues which I talked about, which derive from the nature of medicine, are transformed by this gospel message. Those natural virtues of fidelity, which you hear about, of trust, are raised to the level of grace. So that beneficence is not just a principle. Beneficence becomes charity, the unselfish love of neighbor. Autonomy becomes respect for the dignity of the patient because that patient is created by God in God's image. And justice becomes charitable justice. It's justice without the blindfold. It's not the Roman notion of justice with the two pans. It's justice that looks at the individual, particular, precise needs of this human being here and now. Justice without the blindfold. It is giving and forgiving in imitation of the Father's generosity and not simply giving what is strictly due. So simply put, then, Christian ethics reduces to the central virtue of charity around which the whole life of Jesus was centered. We cannot love a person and treat that person unjustly or maleficently or without regard to her wishes. Charity is a principle as well as a virtue because it is the most fundamental norm of the Christian life. Christian ethics is agapeistic. It brings God's benediction to every healing encounter in the life of the professional. That's the distinction between the obligations we have as Christians. It calls us to perfection, and that's a frightening and an awesome call, but without attempting to respond to it, we cannot be Christian physicians, nurses, or health professionals. I make that point because as we look at managed care today, so many Christian physicians feel overwhelmed by what's happening, by the fact that it's inexorable and that we are in a difficult situation, and therefore exigency would justify our cooperating or accommodating. Remember now, I have not chosen managed care as the great evil. What I have said is that managed care per se is not morally evil, but the way it is being practiced needs to be looked at from the point of view of an ethic which goes beyond ethics, goes beyond ethics. Romano Guardini, a Catholic theologian, in a wonderful meditation on the life of Christ, talks about the ethics beyond ethics. He said, the minute we take ethics to the level of simple rationality, the following of rules, we have lost the spirit of Christian ethics, which goes beyond it and which enters into the realm of the principle of charity. Well, with that perspective, let's look now at some of the conflicts of obligations and interests at the bedside. You will have heard many of these today, but let me look at them afresh from the point of view now of what we are called to do, which means not simply what it is practical to do, or what we're forced to do because of the circumstances, but what we are called to do by our commitment and our claim. Someone said, if you're accused of being a Christian, could you plead guilty? Could we plead guilty? That's the question I would put before you, and we need to put before ourselves. Now, the most urgently felt of the conflicts for the conscientious physician and the nurse is the erosion of the primacy of the commitment to the welfare of the individual patient. This primacy of advocacy to the patient's good is compromised whenever the health professional is an employee of a managed care organization. As an employee, the physician must understand that she has an obligation. She has signed a contract. We tend to forget that. And we have an obligation, therefore, to those who pay us. And that obligation is pitted against our primary obligation to the welfare and the interests and the concerns of this person presenting to us now. In a managed care system, therefore, by its very nature, emphasis is shifted from service to this particular patient to a population-based ethic. And I can't tell you how many times in my discussions with secular ethicists, I'm told over and over again, you must forget this dyadic relationship. You must forget this conviction that all you have to do is take care of this patient. You have to worry about those patients out there. I'm going to say, in the third part of what I have to say, what our obligations are to those people out there. We have a social responsibility, but we must keep it in proper order of priority. Remembering again, managed care depends on how the priorities are established. Financial incentives, when they enter the picture, further confuse it. We have the obligation then to the organization by virtue of contract, obligation indirectly and implicitly to the investors at a distance, and then we are expected to be rewarded and to be punished if we use up the amount of money allocated for X number of patients for Y period of time. Managed care deliberately manipulates the self-interest of the patient, who is a human being, has a family, has needs, manipulates that interest against the interest of the sick person. It's designed that way. The financial incentive is designed to motivate in a particular direction. Now, a fee-for-service system is not without its abuses. Let me say that right at the outset, and I'm not making a plea for fee-for-service. In that plan, the physician earns more the more he does. In managed care, the opposite is true. The physician earns more the less he does. The difference is this. The malfactor in fee-for-service is clearly identified. It is the physician. We know who the perpetrator is. In managed care, the malfactor is the physician as an instrument of another organization of which he is a pawn. And that malfactor is anonymous, not identifiable, can't be seen. And it makes a big difference if you can see your victim and if you can see the malfactor. One of the reasons, for example, that late-term abortions have generated so much revulsion in the American people is that you can see the victim. This is an infant whose brain is being sucked out. It's an infant. You can't see it at 3 months or 2 weeks. So seeing the malfactor is a significant difference. Managed care makes cost containment or profit taking, for the most part, as its end. So its end is not the good of the patient primarily. Now, I understand I'm not castigating anyone. The job of the ethicist is to define where the conflicts are, and I hope you understand that's what I am doing. Not casting aspersions on any human being, but doing what I think every ethicist should do, and that is to raise those annoying questions, and I want to raise them for all of us, including myself, as a Christian. Because managed care and profit-making threaten the most elementary notion of Christian ethics. It converts that covenant of trust and stewardship to a contract for service. It makes the sickness of that particular person a source of profit. It makes health care a commodity, something to be bought and sold on the marketplace. Its distribution, its quality, its accessibility, its availability, determined by the impersonal forces of the marketplace. The marketplace has no place for the loser. It has no place for those who can't enter the market, who don't have the chips to put onto the table. Again, I repeat, the marketplace is a good mechanism imperfect though it be, for most things in our society, but not health care. It also, if you make it a commodity, you give a proprietary right to the physician and the healthcare organization over health care and medical knowledge. Whence did their proprietary rights over medical knowledge derive? Where does medical knowledge come from? When I went to medical school, I took advantage of hundreds of years of observations, of medical research, of literature, of those who preceded me. I was allowed to dissect a human body. You go to jail for that without the social sanction that would allow you to do this. I was allowed to participate and to do autopsies. I was allowed to enter myself into, intrude, let's face it, in the care of human beings who were ill, who came to the university hospital not to see me, but I saw them. Let's reflect on what it is we do in medical education. Let's reflect on where this medical knowledge comes from. I learned as a resident, the surgeon does his first operations. We practice, literally. And there are risks to that. Society permits it. A Christian perspective would permit it. Because properly handled, it is in the interests of all of us to replace doddering old physicians like myself. But can we own that medical knowledge? Can we sell it on the marketplace? Can we make a profit from it? In some organizations going as high as 20%, but in others 7, 8%. If we think of justice in a market sense, all we're required to do is fulfill the conditions of the contract. We have no place for mercy or concern for the person who's made the poor choice. We hear all of this business about, oh, we can choose the plan. The patient is free to choose. Competition, you see. One plan is better than the other. Now, I'm going to challenge most of you to tell me how many plans you've looked at, how much choice you made, and how much choice you had among those plans, and how many of you, the young and the old, can predict what your needs are going to be for health care so that you could wisely choose a plan which will cover the contingencies you're apt to follow. We had a storm come through, could have been a tornado. All of us assembled in this room, could have hit this building. We would have been reduced in an instant from what we consider to be health at the moment to severe illness and disease and death. How can we tell? How can we listen to ethicists who say, well, it's their choice and they have to live with their choice? Is this freedom? What kind of freedom is it? Who chooses? You've heard about the gatekeeper role. I'm not going to say a great deal about it, but I only want to say this. There is a mandatory gatekeeper role which the Christian physician is bound to observe, and that's the gatekeeper role which says we must not provide care which is unnecessary. We all fall under the indictment of having been guilty of doing that at some time in our careers. That's one of the reasons we have this revulsion to fee-for-service. But that's a moral obligation. That's an obligatory gatekeeper role. Pointed out as long ago as Hippocrates, where he points out when the patient is overwhelmed by the disease, the physician ought not to expect medicine to be helpful, A, and B, this is very important, the patient ought not to expect medical care to be helpful. That's Hippocratic. That's 2,500 years old. Morally mandatory gatekeeper role. But the gatekeeper, whose major concern has to be for cost containment and the dispersion of funds or deciding who shall receive care, that role is morally dubious at best. The data are beginning to come in that there are deleterious effects on really sick people. If you're healthy and if you're young, you welcome managed care because you don't have much in the way of needs, your premiums may be lower than they were, you may choose a plan which doesn't have very much in it because you feel you don't need it. For you, the young, it may not be a problem. But the data are coming in with the older patient, the sicker patient. The recent study in the AMA showing that those patients who had strokes did as well in the acute phase, where those of us who are clinicians know the natural history works itself out pretty much no matter what we do, so long as we don't harm the patient. But the rehabilitation phase, which is the most important part, getting that person back to true healing, which is to say putting their lives back together again, that has changed. The hassle factor, which nobody ever talks about, the difficulties of getting care, the frustrations, the impersonality. All physicians are interchangeable. Doesn't make any difference. You don't have to see the same doctor. You've seen a doctor. This is what I'm experiencing. Perhaps others not. But the hassle factor is very significant. A Christian ethic of care focuses on the sick person, the one in need, the one now presenting herself to the physician or the nurse. The sick person, as you heard, is Christ himself seeking help. The wounded healer, who, as Isaiah said, had the knowledge of suffering, had the knowledge of suffering. If we are to be faithful to the vocation of medicine, the calling of medicine, a significant degree of effacement of our own self-interest is essential. As Ecclesiasticus says, healing itself comes from God, the Most High, like a gift received from a king. He has also given some people knowledge so that they may draw credit from his mighty works. Who owns medical knowledge? Where do the antibiotics come from? On the Christian view, medical knowledge is knowledge held in trust. Knowledge God has built into nature, which we may exploit if we use it to help others. To be sure, the physician is entitled and obliged to provide for himself and his family. No one is eradicating that. But this cannot be the primary motivation. The patient is depersonalized. He's an object of trade, or she's an object of trade. As one large corporation merges with the other, the trading pieces are the insured lives. And the less sick those lives are, the better. I'm being very direct, but we need to reflect on what it is we do. We're not consulted about the fact that we've been traded. We have a new corporation now that takes care of us. Everyone will say, well, we don't do that. Well, I just pointed out. Health care is a loss item. It's not the purpose, it's a loss item. And you try to reduce that loss. Remember what I said. It's a reflection of our society, a reflection of who we are and what we are, because we're part of it. I can't stand here and say what I'm saying without fearing that I am also part of that. A whole series of other conflicts, which I'll just mention because you have heard them all day long, but they make my case further. Moral complicity, I don't think anyone's mentioned that. There is no way the physician or the nurse or any other clinician, and the clinician is the one who confronts the patient now, here, in the clinical setting. There is no way we can escape being responsible for what happens to that patient when we write the order or we do not write the order, omission or commission. We are morally complicitous. So therefore, to say that the plan doesn't allow X, Y, and Z, or the plan doesn't do so-and-so, or the plan says you must go to Surgeon Y, whom I know in my heart of hearts has a morbidity and mortality statistic that frightens me, and I have to use him, do I have to use him? Point of moral complicity. We cannot do the Pontius Pilate act. It will not work. It didn't work then, it doesn't work now. We're not freed of legal liability. The law, interestingly, is extremely sensitive to the special nature of the healing physician-patient, nurse-patient relationship. The law of fiduciaries, the law of torts, the law of contracts recognizes that relationship and holds us responsible for the standard of care, not the care that is allowed. And cases are beginning to appear now of the physician being sued for his or her culpability in carrying out the plan quite appropriately, but not providing what the patient needed. We're morally complicitous, we're legally complicitous. And then, you've already heard this, and I'm going to raise it once again. When do we say no? One of the things that modern bioethics hesitates to do is to say that there are some things which ought never to be done. Ought never to be done. I challenge you to think of those things which in medicine and nursing, social welfare, ought never to be done by the professional who professes to be a Christian. When should we say no? When is that responsibility absolutely binding? Without wearing out an old analogy, let me simply say, we know in the Holocaust the physicians did not say no. They didn't say no in the T4 program. They could have. They were not punished, those who said no. Most did not say no. I've gone through 2,000 pages of testimony at the Nuremberg trial, looking for a statement on the part of one of those 20 physicians who were indicted to find an admission of guilt. And all we get are protestations of justification because of what? Exigency, career, fear of punishment, service to the state. It's the law. Everybody else is doing it. Think about those risks. Those are the premises from which the reasoning started that resulted in the justification of an unspeakable evil we call the Holocaust. Again, are we different? Are we, or are we not? German physicians were Christians. Dutch physicians are. Assisted suicide, euthanasia. I was in Holland 3 weeks ago, asked to speak not on assisted suicide, but on the Christian ethics of managed care in a country with a superb medical care system, superb, dangled in front of everyone was, it'll cost you less if you go our way. We make a little profit on it, but it'll cost you less. And to the great, in my view, perceptiveness of one Christian community in Holland, the Dutch Reformed Church, there have begun to ask the Christian question. As a Roman Catholic, I was a little disturbed that my own community hadn't asked me to do this. And the Dutch Reformed were, I assure you, very gracious in inviting someone of my particular denomination to address them. Yet here they were acting perceptively as Christians. Well, I've said enough about, and I could say more about the conflicts. Let me turn now to Do we have a responsibility for cost containment? If we're going to raise the questions I've raised, if we're going to make the judgment based upon a Christian perspective on these conflicts and many others, what are our obligations? Does that mean that we are for open-ended, blank check medicine? Absolutely not. I've already said that there's a moral obligation not to provide care which is not effective, not beneficial, or where the proportionality between the burdens and, yes, the cost emotionally, physically, and so on. The proportionality now, mind you, that's an important distinction. I said this would be a more formal examination of the conflict, where that proportionality is unfavorable. An obligation not to. So that's number one. Our first obligation is to practice effective, safe medicine. And I would say we're all indicted because we have not done that as well as we can or should. And I've been teaching medicine for 52 years, and I'm part of the problem like everyone else. So this would include the overtreatment at the end of life, the mistaken notion that the Hippocratic ethic or the Christian ethic requires us to maintain life and not accept the finitude of our being human beings who die. And when we're called, we're to walk across the water and be received by God, to have that courage, as Peter did not. You remember, he began to sink, and then the Lord brought him up. We're going to have to walk across that water ourselves sometime. We have to understand that. So the first thing we can do, and it happens to be the most economical thing we can do. I don't know how much we spend in excessive unneeded care. The economists tell me something between $30 and $50 billion. I don't know where it is. It's substantial. So that's number one. Clearly, when we're bonded in a covenantal trust with the patient, we can't be a double agent. So when we're with the patient, we are not concerned about cost except as it pertains to this patient. We have an obligation when 2 treatments or 3 treatments are equally effective, beneficial, and have the same proportionality of harm and good, to choose the one which costs less. That's an obligation. Now that's a second kind of obligation, but it is focused on this patient. When we're not in that covenantal bond with this patient presenting to me now, there are a number of things we can do as members of a Christian community, as members of the world community. The first is to support empirical studies to ascertain the relative effectiveness and benefits of treatment. One of the things managed care is bringing in, but under the rubric of cost. Not under the primary rubric of, is this in the interests of patients? Does it increase quality care? Another is to be present, to act as a technical expert. Legislators, policymakers are forever making statements about medicine and clinical medicine. They have consultants, but I don't see too many consultants who are taking into account the fact that the contemplated technique or procedure or benefit or treatment ought to be consistent with some Christian perspective, some common perspective of what is good for humans. Provide reliable data. Avoid pushing our own procedure and technique. That's a matter of self-criticism. Avoid the temptation to advance our own specialty. You're saying, well, you're asking for something that's not going to happen, perhaps. A third measure is to take the leadership in advocating reforms in health care that are going to meet those who are the losers in the marketplace. Let's face it, the poor, the uninsured, the chronically ill, the immigrant, illegal or legal, they're human beings. the heavy users of medical care who are dragging us all down when you look at the model of consumers eating up resources rather than human beings needing care. Those metaphors are very, very important. Those images are important. A fourth is to educate our own patients to the dangers, both physical and fiscal, of unnecessary treatments. This was brought up in one of the discussions. Yes, the patient has obligations too. One of the signal aspects of the 1847 first code of the AMA was that it had a significant piece on the obligations of patients. That's been wiped out. In our book on the virtues in medicine, we have a chapter on the virtuous patient, just as we do on the virtuous physician. Ethics is a matter of mutual obligations. So patients need to exert their ethical responsibilities as well, and Christian patients need to understand it as well. We can help with that. We can educate in living wills and the proper use of them, prepare patients for the end-of-life decisions, and accepting their finitude, theirs and ours. Fifth, here is where we have the opportunity to say no. And that's to avoid entering contracts with for-profit organizations. I'm going to make a statement categorically that a for-profit HMO, not every day, not in every transaction, ultimately must conflict with the welfare of the patient and ultimately must come into conflict with the notion of a Christian commitment, a Christian ethic of care as I've defined it in quick terms. Let's not enter the contract that talks about don't disclose to the patient what's going on. Don't tell them about the patients they're going to. Don't tell them you don't think. Don't say negative things about our program. But that may be necessary for decision-making for the patient. Six, we need to be prepared to define those ethical abuses of the relationship beyond which the erosion of trust relationship is so clearly in violation of any notion of charity that we must say no, and not as individuals, but collectively. Collectively. We cannot put all of these burdens on the individual physician. I would indict our profession as a collectivity now, as a collectivity, for not yet, in a united collective way, recognizing that we must take a stand whenever we see a critical and crucial plan which affects the welfare of those who are ill. We may not form unions. We see many attempts to respond. We'll get back at those people, so we'll form a union. Well, there's nothing wrong with a union if it has to do with collective action for the benefit of the patient. The idea we might go on strike is totally unacceptable. We cannot own shares. Conflict of interest. What I'm talking about is really a conversion, if I may do so. Let me quote from a statement on justice by Pedro Arrupe, who is now deceased, but was the general of the Jesuit order. God's grace, he said, calls us not only to win back our whole selves for God, but to win back our whole world for God. We cannot separate personal conversion from, notice these words, structural social reform. If the final common pathway for the moral status of managed care is what it does to the physician-patient healing relationship to the patient, then the moral status we occupy will depend on how we, in good conscience, approach the day-by-day problem. The burden of conscience on the individual physician is very, very great. Self-righteousness comes easily, but that's only hypocrisy. How far one may cooperate with a morally dubious system is a matter of conscience. I can't tell you what it should be for you. We cannot expect individual physicians, I repeat, to suffer the whole burden. Each of us must balance his other responsibilities. The moral obligation not to cooperate is a communal and collective one. But ultimately, we're talking about the character of the individual physician, the Christian character. Perhaps I should have observed the warning of the Rabbi Akiba in the Talmud that silence is a fence around wisdom. If I had said nothing, you would have no knowledge of my ignorance. But on the other hand, there are some things about which we cannot be indifferent. I don't believe I've exaggerated. I think I've underlined and underscored what a Christian commitment to Christian ethics, which is something more than, the beyond ethics, than secular ethics, which also criticizes managed care. But we go beyond that by looking at what our obligations are. Perhaps we can follow the advice of Father Uribe and recognize that our personal conversion may be the way for structural social reform. Thank you very much.